Good afternoon to you, ladies and gentlemen. My name is Alinda Brenda. I work with Makerere University Laboratories project in their PEPFAR program in the region of Mukono, Kayunga, Buikwe, Buvuma districts. Mine is impact of mentorship on improving quality management systems in peripheral health facility laboratories. And this is basically looking at Mukono district. Mukono district is found still in the center of Uganda. Quality management systems has been on for some time, and currently we are focusing at building the quality management systems, even in the lower health facilities at the village levels. At the hub, Mukono General Hospital, that is where majorly the quality has been building, where the mentorships have been going on, and the hub has reached at a level of a staff 4 right now. And we realize that the other facilities that we serve in the district were not implementing the quality management systems. We receive samples from those facilities. We give them back the results. We also send them some supplies through the Central Public Health Laboratories, but then their quality at the village levels, at those health facilities, was not focused on. So in this presentation, it's more of an experience of a mentor. So we are looking at mentorship being a way of improving quality management systems in those facilities that are served by the hub. So as I said, Mukono General Hospital Hub serves the entire Mukono district, and as a hub, it is being supported by Makerere University Laboratories project and Ministry of Health to be able to serve all the areas in the district. And as a hub, we organized and conducted mentorship programs. At first, we covered 6 facilities. That was 1 hospital. It is a PNFP, that is private, not for profit, Nagalama Hospital. Okay. And then we also covered 5 health facilities, just as a pilot. But as I speak now, we have covered most of the health center 3s in the district, which are around 30 right now. But this presentation is about the first 6 that we started with. That was from October 2021. So in this mentorship, a mentor was given to a facility. Each facility was given a mentor for a certain period. At first, would start going there twice a month, spending maybe 2 days, 3 days, basing on the scope of the facility. Some, for example, like a health center 3 usually has a smaller test menu compared to a hospital or a health center 4. So would give more time to those facilities which have a larger scope. So we were delivering it physically and sometimes through phones and virtually. So we would go. At first, we had a baseline audit to ascertain the level at which the facilities were. In this baseline audit, we used 2 checklists. One was the the common one that we know, the WHO Afro SLIPTA checklist. And then the other was a PEPFAR site improvement through monitoring system. It's called a SIMS assessment tool. And this one basically focuses on the HIV part, HIV monitoring and then advanced HIV disease. But we focused on the laboratory section of that checklist. When we were beginning, most of the labs were at 0. Actually, all the labs were at 0. They didn't have SOPs, especially the health centers. They didn't have any SOP except the bench aids, which had been there for a while. They didn't have any system in place. So we wanted to ascertain the level at which they were. After ascertaining that level, we kept giving the mentorship. Every time we would go, we would have trainings on site, we give CMEs. We also engaged in the facility in charges at these facilities to make sure that we are on the same team, to make sure that they are able to avail the necessary resources within their budget. We also ensured that we leave an action plan. Every time we go for an mentorship, we leave an action plan, and we follow it up on the next mentorship to ensure that whatever was left behind was worked on. We worked on with them one-on-one. Actually, there are times you would find when they are so busy at work, and you have to engage with them to make sure that you first finish the patient load, then you go on and get that audience for them to be able to be interested in, because that's the first challenge that we faced, the patient load vis-a-vis the number of staff at the facility. So we'd go in, engage in the different activities at the facility, and then when we are done, we sit together and we start working on this quality management system. So the results, at first, as I had said, all of them were below the 55% to be able to get a star in using the WHO Afro-SLIPTA checklist. On average, the health centers were at 39%. And the hospital was at 48% at the beginning. So we mentored them for a while, put up we looked at, did some corrective action for all the non-conformities that were identified step by step within the resources that we had. And eventually, we also had an assessment at 3 months. After 3 months, there was an improvement, though it was not so big. The health centers went to 54, which is still within 0 stars, but you would see an improvement. Then the hospital went to 1 star at a 58%. We went on with the mentorships, we went on with the continuous engagements, and finally, after the 9 months, the hospital is currently at a star 2 by end of June 2022, and the rest of the other health centers at a star 1. Then using the other checklist, which is the SIMS checklist, it usually has green, which means meets standard, yellow needs improvement, and red needs urgent remediation. The questions are set that you cannot determine, the percentage is determined per question. That they have different questions. If you meet, then they'll say you're getting a green or yellow or red. So by the end of those 9 months, so far, all the facilities now have green and yellow. None of them has red. The red has been cleared, and they are at 71. The health facilities are 71 using the SIMS checklist, and the hospital lab is at 85% using the WHO, using the SIMS checklist. And then currently, the health facilities at 57%, which is the 1-star rating, using the Afro-SLIPTA checklist. What are some of the measures that we have put in place? It is really a resource-limited area, and the implementing partner is not able to cover most of these expenses for LQMS implementation, but we have continuously engaged the hospital and facility in charges in these areas, and I would want to let you know that they have come on board. As my previous The previous presenter talked about continuous engagement. These people have come on board. Their facilities, you would enter a lab for Health Center 3, and it's just one room, just a table, no benches, no sink. The sink is improvised like these ones in these funny restaurants. And you don't know where to start. The lab, as they call them, lab guys, actually, not even lab people. They would come in and come in anytime, and you find even an askari operating the lab. You cannot locate the staff. But as I can say now, structures have been put in place with the help of the district focal lab person and the district health officer. These labs are now operational. We have the labs, the benches are now there right now as I speak. Structures have changed, and the sinks are now there. And that money was there, but the facility in charges were not engaged in the first place. They were putting all that focus of the finances in other departments like maternity, but lab was not considered. But as we engaged them, right now, the lab that didn't have the sink, the benches, all of them have benches right now. The equipments are being monitored right now. Usually, there are very few, especially for Health Center 3, they have a smaller scope. So you see a difference right now when you go to those facilities. And so among the challenges that we have faced while mentoring is the low staffing. These facilities have like 2 people in the lab. You find a whole lab having 1 person. So that is one of the challenges we have met. So I would like to recommend to ministry if they could look into the staffing structures for these lower health facilities. Because at the hub, at these district hospitals, at referrals, the systems are most of the hubs are accredited and things are moving on well. But we have this patient who is getting the service from the Health Center 3. And if they can't get a quality result at the Health Center 3, that means we shall have many patients sent over for referral to the big hospitals and all that. So this one will miss a good service at a lower health facility. So we would like to engage Ministry of Health to look into the staffing structures. And then originally at the start, there was that negative attitude of personnel towards LQMS implementation. They will say, this is additional work. You're bringing in these things. We are already few. We already have a lot of work. So you're adding in, this is too much for us. We cannot handle it. You're talking about 12 elements of the quality management system. We can't even manage these patients that we have. But currently, as we kept on continuously engaging them, as we kept on training and they bridged that knowledge gap, they are being receptive. Actually, as I talk now, they call you. When they don't see you for a while, you receive a call from them. How far? So far on the action plan, I've worked on this and that, and I need to follow up when you'll be able to come back to the facility so that we can complete this. So you see that the interest is increasing. Another thing, at the hub, we are facing a challenge with return of PT results. We usually receive the EQA panels from the central lab, and then we dispatch through the hub. And the challenge was they were not returning, some of them. You'd call them and they are not interested because they have not appreciated the need. They've not appreciated the importance of these things. But after this mentorship, after engaging them, now when the panels are dispatched from the hub, you get back the results quickly. And if they have any challenge with anything, they'll call you. We've received the panels, but we don't have start pack. Like, they will always communicate of any challenge, which was never the case before this. Then there is also the challenge of limited resources for LQMS implementation. As I had mentioned before, most energy is put at the central labs, at the hub. So you realize there is nothing at the health facilities. You will need stationery. You will need the IQC, the EQA, they are not enrolled on EQA, apart from these ones that are sent through the central system. So if they are running CBC, chemistry, all these other tests that are not catered for, you find that there is no way. But for the hospital, we have been able to improvise. The hub usually receives EQA from HuQAS. So now we send aliquots to the hospital to be able to test. So we are doing interlaboratory comparison with them so that they are able to at least test their services to see using the external quality assurance. So also it's a recommendation that if MOH could look into including LQMS on the lab budget, the labs usually have different budgets for the supplies, but you find things for biosafety are limited, LQMS, it's usually supplies. So if they could include all this on the lab budget, then it will also help in improving the systems at these lower facility levels. So in conclusion, the mentorship program resulted to a significant improvement. We see that the labs that were at 0, currently the hospital is at a star 2 and the other facilities at a star 1. But majorly the challenges that are there are to do structure challenges that we are sending to the management to handle. Some of them we have involved in the district health officer, and he's trying to also support us and see how we can improve in those areas. So mentorship should be incorporated into the laboratory quality management improvements and training programs in order to accelerate the progress of improvement in these laboratories. So as I conclude, I would like to pose a question to us. The presenter before talked about sustaining LQMS in resource-limited areas, but I still also have that question. What next? Right now, we are being supported by partners. Currently, I'm going there because I'm supported by a partner. If these partners are not there, are our hospitals going to remain accredited? Because most of the hospitals have partners. Are our health centers going to remain accredited? Are they going to still maintain these quality systems? So what are we doing to make sure that we sustain these systems, even without these partners coming in to help us? Thank you.